Question 1. General thoracic surgery. Lung cancer management. 65-year-old male with 40-pack year. Smoking history, presence with persistent cough and weight loss. CT scan reveals 3 centimeters mass in the upper lobe of the right lung, and biopsy confirms non-small cell lung cancer (SLC). Staging workup, including PET-CT and brain MRI, shows no evidence of metastases, and mediastinal lymph node biopsy is negative. Pulmonary function tests indicate adequate lung function for surgical resection. What is the most appropriate surgical approach for this patient? A. Segmentectomy. B. Pneumonectomy. C. Lobectomy. D. Stereotactic body radiation therapy. Answer C. Lobectomy. Explanation. Lobectomy is the standard of care for surgically resectable SLC in patients with adequate pulmonary function. Segmentectomy is generally reserved for patients with poor pulmonary reserve or small tumors. Pneumonectomy is considered when the tumor is centrally located or invades major bronchi but is associated with higher morbidity SRTA, a preferred option for inoperable patients due to comorbidities. Relevant guidelines. SEN guidelines of SLC recommend lobectomy with mediastinal lymph node dissection for stage I disease in patients with sufficient pulmonary reserve. The American College of Chest Physicians supports lobectomy as the gold standard for resectable SLC due to superior survival compared to sublobar resections. Question 2. Cardiac surgery. Aortic dissection management. Scenario-based. Dr. Patel, cardiothoracic surgeon, is called to the emergency department to evaluate 55-year-old male with acute chest pain radiating to the back. The patient is hypertensive, BP 109 to 110 Hg, achycardic, and has asymmetric pulses. CT angiogram confirms Stanford-type aortic dissection involving the aorta but not extending into the descending aorta. The patient is hemodynamically stable. What is the most appropriate next step? A. Initiate Roman aorta blockers and monitor in the ICU. B. Perform an emergency surgical repair of the ascending aorta. C. Administer thrombolytics for suspected myocardial infarction. D. Start anticoagulation therapy with heparin. Answer B. Perform an emergency surgical repair of the ascending aorta. Explanation. Stanford-type aortic dissection, which involves the ascending aorta, is a surgical emergency due to the high risk of aortic rupture, cardiac tamponade, and malperfusion syndromes. Immediate surgical repair is required. Why other options are incorrect? A. Beta blockers help control heart rate and blood pressure but are insufficient for type A dissections. Require surgical correction. C. Thrombolytics are contraindicated as they can worsen the dissection by increasing bleeding risk. D. Anticoagulation can exacerbate aortic rupture and is contraindicated in acute aortic dissection unless there is a concomitant indication such as atrial fibrillation. Relevant guidelines. The 2022 American Heart Association American College of Cardiology (EHOC) guidelines state that type aortic dissection necessitates urgent surgical intervention. Medical management Roman aorta blockers is reserved for type B dissections that do not involve the ascending aorta. Question 3. Thoracic surgical oncology. Principles of lymph node dissection. During lung cancer surgery, thoracic surgeon performs systematic mediastinal lymph node dissection to assess for nodal metastases. Which of the following best describes the purpose and benefit of systematic lymph node dissection in lung cancer surgery? A. It reduces the risk of local recurrence and improves overall survival. B. It is only necessary when lymph nodes appear enlarged on preoperative imaging. C. It has no impact on long-term survival and is performed only for staging purposes. D. It should be performed only in patients receiving neoadjuvant therapy. Answer A. It reduces the risk of local recurrence and improves overall survival. Explanation. Systematic lymph node dissection is crucial in lung cancer surgery as it provides accurate staging, guides adjuvant therapy decisions, and improves survival outcomes by ensuring complete removal of nodal disease. Why other options are incorrect? B. Micrometastatic disease may be present even in non-enlarged nodes. Therefore, systematic dissection recommended regardless of preoperative imaging. C. Studies have shown that complete lymphadenectomy improves survival in SLC patients. D. Lymph node dissection is a standard component of lung cancer surgery and is not limited to patients who have received neoadjuvant therapy. Relevant guidelines. The International Association for the Study of Lung Cancer (IASLC) and SEN recommend systematic lymph node dissection in all surgically treated SSLC patients to optimize staging and treatment planning. The American College of Surgeons advises sampling at least 3 mediastinal lymph node stations to ensure accurate staging. Question 4. General thoracic surgery. Lung cancer and surgical resection techniques. 62-year-old male with 40-pack year, smoking history, presence with persistent cough and weight loss over the past 3 months. CT scan reveals 3.5 centimeters mass in the right upper lobe with mediastinal lymphadenopathy. PET scan shows hypermetabolic activity in the mass in the right paratracheal lymph node. Biopsy confirms non-small cell. Cancer ulcer. The patient has a FEV of 2.1, 70% predicted, and diffusion capacity DLEA of 65%. Based on current guidelines for lung cancer staging and management, what is the best initial surgical approach for this patient? A. Segmentectomy of the right upper lobe. B. Pneumonectomy of the right lung. C. Lobectomy of the right upper lobe with mediastinal lymph node dissection. D. Neoadjuvant chemotherapy followed by surgery. Answer. C. Lobectomy of the right upper lobe with mediastinal lymph node dissection. Explanation. Lobectomy with mediastinal lymph node dissection, option C, is the standard treatment for stage R MSLC when there is no distant metastases and the patient has adequate pulmonary reserve. This patient's pulmonary function tests, FEV and ESEO suggest he can tolerate lobectomy. Segmentectomy, option A, is usually reserved for with very poor lung function or small peripheral tumors. Pneumonectomy, option B, is generally avoided due to increased perioperative risks and is only considered if lobectomy is not oncologically sufficient. Neoadjuvant chemotherapy, option D, is typically used for STID-OMNA disease or borderline operable tumors, but is not required here. Question 5. Congenital and pediatric thoracic surgery. Congenital diaphragmatic hernia. Neonate is born at 38 weeks via spontaneous vaginal delivery. Within minutes of birth, the baby exhibits severe respiratory distress with scaphoid abdomen and decreased breath sounds on the left side. An X-ray confirms congenital diaphragmatic hernia (CEH) with bowel loops in the thorax, shifting the mediastinum to the right. What is the appropriate next step in management? A. Immediate intubation and positive pressure ventilation. B. Nasogastric tube decompression and stabilization before surgical repair. C. Emergent thoracotomy and diaphragmatic repair. D. CPAP and observation for spontaneous resolution. Answer. B. Nasogastric tube decompression and stabilization before surgical repair. Explanation. Congenital diaphragmatic hernia (CEH) causes pulmonary hypoplasia and respiratory distress at birth. The immediate priority is to avoid bag mask ventilation, which can worsen bowel distension and lung compression. Instead, NG tube decompression and gentle ventilation with intubation, option B, are critical to prevent further pulmonary compromise. Surgery, option C, is necessary but should be delayed until the infant is hemodynamically stable. CPAP, option D, is contraindicated because it can exacerbate pulmonary compression. Question 6. Cardiac surgery. Aortic dissection classification and management. 55-year-old male with history of hypertension presents to the emergency department with severe tearing chest pain radiating to his back. CT angiogram reveals Stanford-type aortic dissection involving the ascending aorta but sparing the descending aorta. His blood pressure is 180 to 100 TAHG. What is the most appropriate mat? For this patient, A. Immediate surgical repair of the ascending aorta. Rotator blockers and observation in the IQ. C. Endovascular repair with stent graft. D. Administration of thrombolytics to reduce clot burden. Answer A. Immediate surgical repair of the ascending aorta. Explanation. Stanford-type aortic dissection, option A, is a surgical emergency due to the risk of rupture, cardiac tamponade, or aortic regurgitation. Immediate open repair is the only definitive treatment. Beta blockers, option B, help control blood pressure but are insufficient as monotherapy. Endovascular repair, option C, is reserved for Stanford type B dissections affecting only the descending aorta. Thrombolytics, option D, are contraindicated as they can worsen bleeding. Question 7. Scenario-based. Perioperative care and risk stratification. Dr. Patel, thoracic surgeon, is evaluating 72-year-old female with history of chronic obstructive pulmonary disease, COPD, and coronary artery disease who is scheduled for an esophagectomy due to esophageal adenocarcinoma. Pulmonary function testing shows a FEV of 45% predicted and cardiac stress test indicates moderate river ischemia. Which of the following preoperative interventions is most critical to reducing her surgical risk? A. Smoking cessation and pulmonary rehabilitation. B. Prophylactic coronary artery stenting. C. Immediate administration of bronchodilators and steroids. D. Postponing surgery until cancer progression is evident. Answer 8. Smoking cessation and pulmonary rehabilitation. Explanation. Optimizing lung function with smoking cessation and pulmonary rehabilitation, option A, is crucial to reduce postoperative pulmonary complications. Prophylactic coronary stenting, option B, is not recommended unless the patient has unstable coronary disease. Bronchodilators and steroids, option C, may help but do not replace long-term preoperative pulmonary optimization. Delaying surgery, option D, increases cancer progression risk and is not appropriate. Question 8. Minimally invasive and robotic thoracic surgery. VATS lobectomy versus open lobectomy. 58-year-old male with early stage SSLC is considering surgical options. He is offered both video-assisted thoracoscopic surgery, VATS lobectomy, and an open lobectomy. He asks about the advantages of the minimally invasive approach. Which of the following statements is the most accurate? A. VATS lobectomy results in lower postoperative pain and shorter hospital stays compared to open lobectomy. B. Open lobectomy has lower overall mortality rates compared to VATS. C. VATS lobectomy is contraindicated for any tumor larger than 2 centimeters. D. There is no difference in postoperative complication rates between VATS and open lobectomy. Answer A. VATS lobectomy results in lower postoperative pain and shorter hospital stays compared to open lobectomy. Explanation. VATS lobectomy, option A, is associated with reduced pain, shorter hospital stays, and faster recovery. Studies have shown equivalent or superior outcomes compared to open lobectomy. Open lobectomy, option B, does not have lower mortality than VATS. VATS is not contraindicated for tumors 2 centimeters, option C, and evidence suggests that complication rates may actually be lower with VATS than open surgery, option D. Question 9. Vascular and endovascular surgery. Pulmonary embolism management. 45-year-old female presents with sudden onset dyspnea, tachycardia, and hypotension. CT pulmonary angiogram confirms massive pulmonary embolism P with right ventricular strain. Despite fluid resuscitation, her blood pressure remains at 80 G. What is the most appropriate next step? A. Systemic thrombolysis with alteplase. B. Immediate pulmonary embolectomy. C. Therapeutic anticoagulation with heparin. D. Placement of an inferior vena cava filter. Answer A. Systemic thrombolysis with alteplase. Explanation. Massive P with hemodynamic instability requires systemic thrombolysis, option A, unless contraindicated. Surgical embolectomy, option B, is reserved for patients who fail thrombolysis. Anticoagulation alone, option C, is insufficient for massive P with shock. Filters, option D, are used for recurrent PES when anticoagulation is contraindicated. Question 10. Ethics and professionalism. End-of-life decision-making in surgery. 68-year-old patient with metastatic lung cancer is admitted with malignant pleural effusion and severe dyspnea. The patient is unconscious and his advance directive states he does not want aggressive interventions. His family insists on placing the patient on ventilator. What is the surgeon's ethical responsibility? A. Honor the advance directive and avoid intubation. B. Proceed with intubation since the family has requested it. C. Transfer the patient to another hospital to avoid conflict. D. Initiate full resuscitation efforts until court order is obtained. Answer A. Honor the advance directive and avoid intubation. Explanation. The surgeon must follow the patient's advance directive, option A, which reflects their autonomy. Family wishes do not override legally binding directives. Transferring the patient, option C, or resuscitation, option D, would be inappropriate. Question 11. General thoracic surgery. Tracheobronchial injury management. 34-year-old male is involved in high-speed motor vehicle collision. He arrives at the emergency department with respiratory distress, subcutaneous emphysema, and hemoptysis. Chest X-ray reveals pneumomediastinum and right-sided pneumothorax. Bronchoscopy confirms 2 centimeters tracheobronchial tear at the carina. What is the most appropriate next in management? A. Immediate surgical repair via right thoracotomy. B. Observation with serial bronchoscopy and supportive care. C. Placement of tracheostomy for airway protection. D. Intubation with the endotracheal tube advanced past the injury. Answer A. Immediate surgical repair via right thoracotomy. Explanation: large tracheobronchial injuries, 2 centimeters, require immediate surgical repair. Option A. To prevent progressive respiratory failure. Observation: Option B is appropriate only for small, stable injuries. Tracheostomy. Option C is not the first-line treatment for acute injuries. Advancing an endobronchial tube. Option D may help stabilize the airway, does not replace definitive surgical repair. Question 12. Esophageal surgery. Management of esophageal perforation. 59-year-old male with history of alcoholism, presence with severe retrosternal chest pain after repeated episodes of vomiting. CT scan with oral contrast shows extravasation into the mediastinum. His vitals are stable. What is the most appropriate initial treatment? A. Immediate esophagectomy with reconstruction. B. Broad-spectrum Roman antibiotic, NPO, and drainage. C. Placement of an esophageal stent and discharge home. D. Emergency endoscopy with balloon dilation. Answer B. Broad-spectrum Roman antibiotics, NPO, and drainage. Explanation: Boerhaave syndrome, spontaneous esophageal perforation, requires immediate Roman antibiotics, bowel rest, and drainage. Option B. Esophagectomy. Option A is reserved for severe cases with extensive necrosis. Esophageal stents. Option C are useful but not first line in acute settings. Endoscopy. Option D may worsen the injury. Question 13. Thoracic oncology. Malignant pleural effusion management. 65-year-old female with metastatic breast cancer, presents with worsening dyspnea. Chest X-ray reveals large right-sided pleural effusion. Thoracentesis confirms malignant cells. What is the best long-term management strategy? A. Repeat thoracentesis as needed. B. Chemical pleurodesis via chest tube. C. Immediate VATS pleurectomy. D. Insertion of an endobronchial valve. Answer B. Chemical pleurodesis via chest tube. Explanation: Chemical pleuresis. Option B is the preferred management for recurrent malignant pleural effusions. Repeat thoracentesis. Option A provides temporary relief but is not ideal long-term. VATS pleurectomy. Option C is used when pleurodesis fails. Endobronchial valves. Option D are not used for pleural effusions. Question 14. Cardiac surgery. Valve repair versus replacement in aortic stenosis. 72-year-old male with severe symptomatic aortic stenosis. Valve area 0.8 cm. Presence for evaluation. His echocardiogram shows left ventricular ejection fraction of 50%. What is the most appropriate surgical intervention? A. Aortic valve repair. B. Surgical aortic valve replacement. SAVR. C. Transcatheter aortic valve replacement. TAVR. D. Balloon valvuloplasty. Answer B. Surgical aortic valve replacement. SAVR. Explanation: SAVR. Option B is the gold standard for operable patients with severe aortic stenosis. TAVR. Option C is an alternative for high-risk or inoperable patients. Valve repair. Option A is rarely performed. Balloon valvuloplasty. Option D is temporary and used mainly for bridge therapy. Question 15. Scenario-based. Postoperative complications in thoracic surgery. 67-year-old male undergoes right pneumonectomy for lung cancer. On postoperative day 3, he develops acute hypotension, tachycardia, and tracheal deviation toward the left side. Breath sounds are absent on the right. What is the most likely diagnosis? A. Pulmonary embolism. B. Post-pneumotomy syndrome. C. Tension pneumothorax. D. Post-pneumotomy bronchopleural fistula. Answer D. Post-pneumotomy bronchopleural fistula. Explanation: a bronchopleural fistula, option D, can cause massive air leakage into the pleural space, leading to mediastinal shift and respiratory distress. Pulmonary embolism, option A, does not cause tracheal deviation. Post-pneumonectomy syndrome, option B, is a chronic condition, not an acute postoperative event. Tension pneumothorax, option C, is unlikely because pneumonectomy space should not contain lung tissue. Question 16. Minimally invasive surgery. Robotic-assisted lobectomy. 60-year-old male with 2 cm peripheral lung nodule is scheduled for lobectomy. The surgeon offers robotic-assisted approach instead of traditional thoracotomy. What is key advantage of robotic-assisted lobectomy? A. Reduced risk of conversion to open surgery. B. Improved postoperative pulmonary function. C. Faster tumor resection time compared to VATS. D. Low risk of oncologic recurrence. Answer B. Improved postoperative pulmonary function. Explanation: robotic-assisted lobectomy. Option B. Improved postoperative recovery and preserves lung function. It does not necessarily reduce conversion to open surgery. Option A. Compared to VATS, tumor resection time. Option C is often longer. Oncologic recurrence rates. Option D are similar to other approaches. Question 17. Vascular surgery. Management of subclavian steal syndrome. 58-year-old female presents with dizziness, arm claudication, and syncope when using her left arm. Duplex ultrasound reveals retrograde flow in the left vertebral artery. What is the best treatment option? A. Carotid endarterectomy. B. Subclavian artery stenting. C. Vertebral artery ligation. D. Physical therapy and observation. Answer: B. Subclavian artery stenting. Explanation: subclavian steal syndrome is caused by proximal subclavian artery stenosis leading to retrograde vertebral artery flow. Stenting, option B, is the preferred treatment. Endarterectomy, option A, is not used for subclavian disease. Vertebral artery ligation, option C, is inappropriate. Observation, option D, is insufficient for symptomatic patients. Question 18. Pediatric thoracic surgery. Pectus excavatum repair. 15-year-old male presents with severe pectus excavatum and symptoms of exertional dyspnea. What is the preferred surgical approach? A. Nuss procedure with bar placement. B. Ravage procedure with sternotomy. C. Observation until adulthood. D. External bracing therapy. Answer A. Nuss procedure with BART placement. Explanation: the Nuss procedure, option A, is the preferred minimally invasive approach for pectus excavatum in adolescents. The Ravage procedure, option B, is more invasive and used in complex cases. Observation, option C, is not ideal for symptomatic patients. External bracing, option D, is only effective in mild cases. Question 19. Lung transplantation. Indications and contraindications. 55-year-old male with end-stage idiopathic pulmonary fibrosis is being evaluated for lung transplantation. Which of the following is an absolute contraindication? A. Age 65 years. B. BMI of 34. C. Severe coronary artery disease with reduced ejection fraction. D. Long-term oxygen therapy dependence. Answer: C. Severe coronary artery disease with reduced ejection fraction. Explanation: severe coronary artery disease, option C, with poor cardiac function is an absolute contraindication for lung transplantation. Age 65, option A, and obesity, option B, are relative contraindications. Oxygen therapy, option D, is not a contraindication. Question 20. Ethics. Informed consent in high-risk surgery. Patient with stenoesophageal cancer requires an esophagectomy but refuses surgery due to fear of complications. How should the surgeon proceed? A. Perform the surgery under implied consent. B. Proceed with chemotherapy only. C. Reassess the patient's understanding and respect their decision. D. Seek court intervention for mandatory surgery. Answer: C. Reassess the patient's understanding and respect their decision. Explanation: patients have the right to refuse surgery, option C, after receiving full information. Surgery cannot be forced, option D. Implied consent, option A, is not valid here. Chemotherapy alone, option B, is not substitute for an informed decision. Question 21. Thoracic surgery. Management of postoperative air leak. 65-year-old male undergoes right upper lobectomy for non-small cell lung cancer. On postoperative day 4, his chest tube continues to show an air leak during inspiration and expiration. CT scan shows no evidence of pneumothorax or fluid collection. What is the most appropriate next step? A. Remove the chest tube and monitor. B. Perform bronchoscopy to evaluate for bronchopleural fistula. C. Return to the operating room for surgical repair. D. Initiate positive pressure ventilation to seal the leak. Answer: B. Perform bronchoscopy to evaluate for a bronchopleural fistula. Explanation: persistent postoperative air leak suggests a bronchopleural fistula (BPF) or a prolonged alveolar-pleural fistula. Bronchoscopy, option B, is the best next step to evaluate for BPF. Chest tube removal, option A, without identifying the source risks worsening pneumothorax. Surgical repair, option C, may be necessary but is not immediate next step. Positive pressure ventilation, option D, may exacerbate the air leak. Question 22. Lung cancer. Staging and surgical management. 58-year-old male presents with 4 cm mass in the right upper lobe. PET scan shows no distant metastasis, but mediastinal lymph nodes are positive on EBIS biopsy. What is the most appropriate next step? A. Proceed with lobectomy. B. Induction chemotherapy followed by reevaluation for surgery. C. Radiation therapy alone. D. Immediate pneumonectomy. Answer: B. Induction chemotherapy followed by reevaluation for surgery. Explanation: mediastinal lymph node involvement and disease suggests stage A lung cancer. Induction chemotherapy, option B, followed by reevaluation is preferred. Lobectomy, option A, is inadequate without addressing nodal disease. Radiation alone, option C, is not curative in this stage. Pneumonectomy, option D, is overly aggressive and not indicated without downstaging. Question 23. Cardiac surgery. CAB versus PCI decision-making. 72-year-old male with diabetes and multivessel coronary artery disease. CAB presents with stable angina. Angiography shows 70% stenosis of the left anterior descending LAD right coronary and circumflex arteries. What is the best long-term management? A. Medical therapy alone. B. Percutaneous coronary intervention (ECI) with stenting. C. Coronary artery bypass grafting. CAB. D. Implantation of an LVAD. Answer: C. Coronary artery bypass grafting. CAB. Explanation: CAB option C is preferred in diabetic patients with multivessel care due to better long-term survival. ECI option B is inferior for multivessel disease in diabetics. Medical therapy alone, option A, does not adequately address ischemia. LVAD option D is for end-stage heart failure, not CAD. Question 24. Esophageal surgery. Barrett's esophagus with high-grade dysplasia. 60-year-old male with Barrett's esophagus undergoes surveillance endoscopy, which reveals high-grade dysplasia. What is the most appropriate next step? A. Esophagectomy. B. Continued surveillance endoscopy every 3 months. C. Proton pump inhibitors, PPIs alone. D. Endoscopic dilation. Answer A. Esophagectomy. Explanation: high-grade dysplasia is a precursor to esophageal adenocarcinoma, warranting esophagectomy. Option A in fit patients. Surveillance. Option B alone risks progression. PPIs. Option C reduce acid exposure but do not prevent malignancy. Dilation. Option D does not treat dysplasia. Question 25. Aortic dissection. Type versus Type B management. 55-year-old male presents with acute tearing chest pain radiating to the back. CT angiogram shows Stanford type aortic dissection involving the ascending aorta. What is the most appropriate management? A. Urgent surgical repair. Rominator blockers and observation. C. Endovascular stent placement. D. Medical therapy followed by elective repair. Answer A. Urgent surgical repair. Explanation: type aortic dissections require emergency surgery. Option A, due to the risk of rupture and tamponade. Medical therapy. Option B, D, is appropriate for type B dissections, but not type A. Endovascular repair. Option C is generally used for type B. Question 26. Congenital heart surgery. Tetralogy of Fowler repair. 6-month-old infant with tetralogy of Fowler experiences frequent cyanotic spells. What is the definitive treatment? A. Propranolol therapy. B. Blalock Thoracic shunt placement. C. Complete surgical repair with VSD closure and arvot widening. D. Balloon valvuloplasty. Answer: C. Complete surgical repair with VSD closure and arvot widening. Explanation: definitive treatment for tetralogy of Fowler is complete surgical repair. Option C. Beta blockers. Option A are a temporary measure. A Blalock Thoracic shunt. Option B is a palliative option. Balloon valvuloplasty. Option D does not correct all defects. Question 27. Pulmonary embolism. Indications for surgical embolectomy. 45-year-old male presents with massive pulmonary embolism and cardiogenic shock. Is hemodynamically unstable despite thrombolytic therapy. What is the next step? A. Catheter-directed thrombolysis. B. Surgical pulmonary embolectomy. C. Heparin infusion alone. D. Inferior vena cava if filter placement. Answer: B. Surgical pulmonary embolectomy. And explanation: surgical embolectomy, option B, is indicated for massive P with shock when thrombolysis fails. Catheter-directed thrombolysis, option A, is used for submassive P. Heparin alone, option C, is insufficient. IV filters, option D, prevent recurrence but do not treat acute P. Question 20. Mediastinal mass thymoma versus lymphoma workup. 42-year-old female presents with an anterior mediastinal mass found incidentally on CT. She has mild myasthenia gravis symptoms. What is the most likely diagnosis? A. Thymoma. B. Hodgkin's lymphoma. C. Teratoma. D. Neurogenic tumor. Answer A. Thymoma. Explanation. Thymomas, option A, commonly present in middle-aged adults and are associated with myasthenia gravis. Hodgkin's lymphoma, option B, usually presents with systemic symptoms. Teratomas, option C, are often asymptomatic. Neurogenic tumors, option D, are usually posterior mediastinal masses. Question 29. Cardiac surgery. Indications for ECMO in cardiogenic shock. 50-year-old male with massive myocardial infarction develops refractory cardiogenic shock despite inotropes and intra-aortic balloon pump support. What is the best next step? A. Urgent coronary artery bypass grafting CAB. B. Percutaneous left ventricular assist device LVAD. C. Extracorporeal membrane oxygenation ECMO. D. High-dose vasopressors. Answer C. Extracorporeal membrane oxygenation ECMO. Explanation. ECMO option C provides circulatory support in refractory cardiogenic shock. CAB option A may be needed later but is not an immediate rescue therapy. LVAD option B is for chronic heart failure. High-dose vasopressors option D worsen ischemia. Question 30. Lung transplant. Primary graft dysfunction management. 55-year-old male undergoes bilateral lung transplantation. Within 24 hours, he develops severe hypoxemia, diffuse pulmonary infiltrates, and low lung compliance. What is the best initial treatment? A. High-dose corticosteroids. B. Inhaled nitric oxide. C. Plasmapheresis. D. Antibiotic therapy. Answer B. Inhaled nitric oxide. Explanation. Primary graft dysfunction (PGD) is a form of acute lung injury post-transplant. Inhaled nitric oxide, option B, reduces pulmonary hypertension and improves oxygenation. Steroids, option A, have limited benefit. Plasmapheresis, option C, is used for antibody-mediated rejection. Antibiotics, option D, are used if infection is suspected.